Good evening, everyone present here. I am Faraz from IGCP Group. Welcome all the participants on today's webinar that is on a very important topic, that is pituitary incidentaloma, a step-by-step clinical approach. As we know that this topic is very much important, so we need someone who is expert. So we would like to invite our speaker with great honor, none other than Dr. Anirban Sinha sir. And let me share some of the achievement of sir. Sir has done MD, DM in endocrinology, FACE, and he is associate professor at the Department of Endocrinology at Medical College Kolkata, and he is visiting consultant at Amri Hospital, chairman of Ethics Committee, Central Hospital, SER. So without any further delay, I would like to invite sir and hand over this webinar to sir. Sir, the stage is yours. You can proceed from here. Over to you, sir.
Okay. Thank you very much for your kind introduction. Today, we are uh, going to talk on pituitary concerns like pituitary incidentaloma. What happens is when you say, for example, you had a head injury, you go for a CT scan or an MRI, or even if you have a stroke or suspected stroke, you had an MRI and you detect a tumor in the pituitary, but you did not have any previous complaints. That is called as incidentaloma. It can be anywhere. Incidental finding is called as incidentaloma. Maybe most commonly in endocrine, we deal with pituitary and adrenal incidentaloma, but adrenal glands and pituitary. But otherwise, it can be anywhere. Any gland can have isolated tumor, which is not have obvious symptomatic presentation. That is classically called as incidentaloma. And today's talk is on pituitary incidentaloma. So we'll go through, this is the flow of my talk: introduction, silent pituitary adenoma, then diagnosis management, then special consideration, then cystic pituitary incidentaloma, then other differentials. So first is why and what it is. So it is actually a cellular or paracellular finding incidentally discovered during imaging, not undertaken because of suspected pituitary lesion. Although the features of hormone excess, hypopituitarism, both can be a presentation of obvious pituitary tumor or mass effect, that is the third effect, where the enlarging mass compresses the surrounding structure. And imaging is not undertaken because of the suspected pituitary lesion. As I said, the incidentoma is incidentally detected. So patients are not being investigated for that and incidentally found with along with the co-finding along with the primary pathology looked for. All other lesions discovered incidentally. Most common is the pituitary adenoma, or other findings around the pituitaries are Rattler's cave cyst or empty cella. These are again incidental findings. And but most common it is the tumor, which is adenoma, which patient thinks it is scary and needs evaluation. Clinically non-functioning pituitary adenomas comprise only one type of incidentaloma. It is classically called as NFPA, or pituitary incidentalomas are often interchangeably used, but it is not actually so. There are many other forms of pituitary adenomas are there. NFPA accounts for 30 to 55% of pituitary adenoma, second most common after the prolactinoma, which is the most common pituitary tumor and functioning pituitary tumor we see in our endocrine practice. So non-functioning tumors are almost as close to the most common functioning tumor. So non-functioning tumor is the second common after prolactinoma. So understand how assuring it can be. So most of the time it is likely that your tumor, if incidentally detected, it is not functioning. Pituitary adenomas are predominantly benign and clinically indolent, and morbid results mostly from hormonal hypersecretion or compression around the local structure. Classically divided two groups: micro and macro tumors, less than 1 centimeter or more than 1 centimeter. Less than 1 centimeter has no overt signs and symptoms. Usually no hormonal hyper or hyposecretion. Macro functions are associated with visual field changes, cavernous sinus invasions, and other point of identification. And adenomas, as I said, 10 to 20% of all neoplasm is detected in the routine scan. So it is quite common in MRI of the pituitary or in the brain actually. Pituitary insulinoma differential diagnosis are good, very huge. So that should be kept in mind when we exclude that these are not there and only the adenoma is the concern. It can be adenoma, it can be hyperplasia, it can be carcinoma as well, incidentally detected, though rare, still possible. Then it can be cavernous carotid aneurysms. It can be arteriovenous malformation, rachis, as I said, this is the second most common. And then the cystic pituitary adenoma. There may be dermoid, there may be epidermoid, there may be pituitary, suprapituitary area. Stalk of the pituitary may be inflamed, looks like a pituitary tumor, like hypophysitis, may be of any cause, like lymphocytic hypophysitis, granulomatous, or IgG4 disease. Even the tumors around the pituitary, like the craniopharyngioma, meningioma, metastatic tumors from the very commonly seen from the lungs, breast, or colon cancers. These are even the lymphoma may be seen around pituitary. This is incidentally, so that looks like incidentoma. So what I mean, and there are empty cell, as I said, idiopathic empty cell is possible, or maybe the secondary pituitary atrophy because of the apoplexy or hypophysitis. And there may be pseudotuberous cerebri, like the idiopathic intracranial hypertension may be associated with. There are infiltrative pathologies like sarcoidosis, amyloidosis, which patient has other systemic presentation. We need to exclude this. And again, infection still remains one of the causes like bacterial tubercular abscess, fungal infection, and variants of normal anatomy is still a possibility to exclude all the after excluding all the other causes. Indication, what are the indications for imaging for insulinoma? This is a study of single center around 400 patients. Most common presentation were his headache, visual loss, cranial palsy, sinusitis, mastoiditis, tinnitus, vertigo, syncope. Even as I said, the cerebrovascular accidents, trauma, brain metastasis, of looking for other obvious present primary tumors, and follow-up of the non-pituitary brain mass. Maybe for other brain mass was there before, and follow-up we incidentally find that. Even the dental X-ray incidentally helps you to detect that. So this is a data on clinical and pathological aspects of silent pituitary adenomas. This is the classification of adenomas. What are the cell lineage which are associated with, and what are the pituitary hormones and the transcription factors which are related to it, like somatotroph adenoma, lactotroph adenoma, thyrotroph adenoma, corticotroph or the cortisol secreting adenoma, gonadotrophs or the FSH-LH secreting. We understand, we can see that values and the pituitary hormones related to and the transcription factors, because developmental association is also there. So these factors are associated with these adenomas, even null cell adenomas and the one positive tumors. What is important is silent pituitary adenoma refers to tumors that express one or more anti-pituitary hormones, and null cell adenomas are exceedingly rare primary tumors in that hormone negative and does not express any of the pituitary transcription factors. All diagnosis is clinically defined as non-functioning pituitary adenoma could be converted to special functioning pituitary adenoma. So these are interchangeable. So that is the reason we need to look for it. But all the factors that could be there, maybe a somatotrope, maybe lactotrope, thyrotrope, all the components of pituitary may become adenomatous and makes a pituitary tumor. So this is the thing we should remember. And as I said, the prolactinoma is the most common. So even if the patient is not symptomatic, maybe we need to exclude that as well. So this is WHO 2017 classification of adenomas. As I said, densely granulated and sparsely granulated. Those depending on the mutagenesis, and lactotroph adenomas, thyrotroph, as I said, different factors are there. So we can see here, this is the growth hormone prolactin, mostly it is that, but corticoadenomas are the diffuse pattern, and these are the transcription factors. Its genetic detection is still possible, and gonadotroph adenomas are also there. They are mostly sparsely granulated, and that helps detect the tumors as well. So this is a paper on endocrine oncology showing the WHO classification of pituitary tumors. I'm not going in details of it, but it is mostly the same. And as I said, it is main two classification is silent pituitary adenoma and null cell adenoma, which does not show any of the transcription factors, and it is negative hormone and transcription factor sharing, so it does not have any risk of future prognosis. But most of the time, when it has a silent pituitary adenoma, this still can has a potential secretion factors like all the tumors properties like LH, FSH, ACTH, plurihormonal, multiple hormones secreted together, prolactin, growth hormone, all these things can be a secretive pattern. So this is what the continuous spectrum of silent and functioning adenoma. We can see clinically silent, biochemically silent, then clinically biochemically silent, and then hormone negative, but transcription factors are positive. That is slightly higher risk. We can see here. Here all the things are negative. Here only the transcription factor positive. Then there are both clinically biochemically silent, they're hormone positive, transcription factor positive, then clinically silent, biochemically mildly active, hormones are positive, and still transcription factor positive. So these are clinically silent, but very potentially converting to the active forms, like they are still biochemically mildly elevated, and hormone studies did show the positive and clinically borderline, ultimately clinically positive to make it a functioning one. So this is actually a spectrum. We need to look for where the patient is there. This is the silent corticotroph adenomas. Immunostain is important. As I said, all the tumors with the tumor cell lineage can be detected by the immunostain, which mostly secrete ACTH and POMC, but clinically silent. And aggressive variants, 20% of surgically removed adenoma belongs to these categories. And silent type 3 adenomas usually express growth hormone, prolactin, or TSH. Again, these are aggressives. And silent growth hormone secretory adenomas are 2% of all adenomas. Patients should be followed postoperatively for recurrence and progression to acromegaly, because the growth hormone secreting tumors that can be end up in excess growth hormone effects even after operation. So need a close follow-up. So mostly what we look for is the visual field defects, extraocular muscle defects because of the findings, silent tumors where the compression is a potential concern. Then we look for the mild presentation of hormone excess like amenorrhea, decreased libido. Then the hormonal deficiency, like the compression effect can also cause hormonal deficiency as well as excess. So growth hormone, LH, TSH, ACTH, and then when the DI, that is diabetes insipidus, looked for, and some patient has a history of apoplexy, pituitary apoplexy should be looked for. Immunostaining, again, gonadotroph is 44%, that is most common. This is the consensus guideline, came out in June 2025, quite recent, in a year back. So this is where the endocrinologist consultation is warranted. That is a guideline we are talking about. Adenoma maximum diameter more than 10 millimeter or cavernous invasion. Evidence of 20 to 15 to 20% growth of the maximum diameter compared to the previous imaging. Presence of visual field defects, ophthalmoplegia or severe headache. Clinical features of hypopituitarism or hormone hypersecretion. So all this presentation if present, patient usually requires a endocrine referral to us. And dedicated pituitary imaging when it is required. At diagnosis, as I said, if they're suspected, MRI with pituitary detailed sequencing, that is maybe a dynamic scan or detailed sequencing by other measures because cellular need to be looked closely. Gadolinium enhancement is to be used unless contraindicated. Standardized imaging is T1 weighted spin echo MRI, coronal and sagittal plane, pre and post gadolinium, T2 fast pin. These are the technical terms, but again, we need to know why and where it is required. And again, slice thickness should be less than 3 millimeter to detect the tumor in a small tumor, especially. Might be existing images provide sufficient information, and then we may not be repeating a diagnosis. But if the first imaging is good enough for localization and the extent of the tumor properly, and other factors are not so concerning. So interval for the recurrent surveillance. That is very important, whether the tumor is benign or not. Microadenoma every 2 to 3 years initially, and macroadenoma more than 5 millimeter, that is uh, away from the optic chiasma of 1 year. And if they're less than 5 millimeter away from the optic chiasma, that is very close to the optic chiasma, whereas the risk of compression is high, then it is 6 to 12 months interval is required. Again, it is the first follow-up, and if the patient, it all depends on the progression of the tumor and the changes and the subsequent effects. So it is not a fixed effect, but mostly this is the guideline we talking about. Slowly growing tumor, then stable tumors less than 5 millimeter away, usually 1 to 2 years, and macroadenomas even more than 5 millimeter away from the optic chiasma, because optic chiasma is a very important landmark to avoid the blindness and effect of alteration of visual field defects. And so enlarging invasive tumors, we may require frequent intervals because it depends on the how frequently the patient tumor grows. A new and worsening signs and symptoms, not only the tumor, but if the patient presents with within, say, if you are present, expected to be done within 2 to 3 years in a microadenoma, but patient reappears after 6 months with the new onset signs and symptoms, then maybe aggressive follow-up required. Predictor for adenoma growth, this is important in the initial as well as subsequent follow-ups. Adenoma height more than 15 millimeter in the site size at diagnosis. Location less than 1 millimeter from the optic chiasma. Pituitary stalk deviation. Hormone deficiency at diagnosis, because likely it is destroying the surrounding structure. Lesion appearing solid on imaging because it is full of cells, and it is expected to be growing rapidly. Contrast enhancement with T1 weighted and increased signal intensity in T2 images. Again, it did show that it has a active activities of the tumors. Approximately 40 to 45% of the macroadenomas show increased diameter or volume within 3 to 4 years, and an additional 5 to 10% grow when the followed up for more than 4 years. So this is to be kept in mind. Initial diameter and the rapid growth within first 3 to 4 years is most important. After that, maybe if the patient is not growing after 4 years of sequence, 4 to 5 years of follow-up, then maybe we delay the subsequent visits. Compared to the microadenoma and macroadenoma with the high fivefold higher risk of apoplexy, because larger the tumor, higher the risk of interbreed, and because of the ischemia, infarct is much more, fourfold increased risk of visual field defects, and threefold risk of pituitary hormone deficiency. When considering the growth based on size, none of the microadenomas less than 5 millimeter or 14% of those more than 5 millimeter grew during the follow-up. Initial adenoma size, sex, and age did not affect the median time for growth. So these are all study data we are talking about. And a growth of 5 to 5.9 millimeter per year, as well as an increase in the 3.5 millimeter overall predictive deteriorating the visual symptoms, and a macroadenoma volume growth rate more than 10 millimeters cube per month increase assessed at the 2 years were highly predictive of requirement of surgery. So that is the importance of serial follow-up, so that we understand what to do and when not to do the judgments. Discontinuation. Microadenomas less than 5 millimeter remain stable in the repeat MRI for up to 2 to 3 years time. Need to be continued imaging depending on the situation. Repeat imaging after another 5 years, and before discontinuing surveillance is another option. If the microadenoma more than 5 millimeter with reviews suggested at 6 months, then annually, because if the tumor is more than 5 millimeter, it is likely possibly to be grow to the macroadenoma state. So risk is intermediate between the true microadenoma and macroadenomas that is more than 10 millimeter, and also we need to be followed up stably. And if size remains stable in the macroadenoma cases, that imaging could be preferred less frequently, eventually discontinued depending on the patient's situation and the signs symptoms. But again, patient's routine monitoring as a clinical signs and symptoms should be continued if required hormonal functioning as well. These are the endocrine stimulation. Now we are talking pituitary hormones. Testing is preferred in all patients with incidental cellular lesion, secreting patient's tumor with prolactin IGF-1 to be done in all patients incidentally discovered pituitary adenomas because, as I said, the risk of hyperfunctioning is maximum of these two hormones. Hypercortisolism should be performed with clinically warranted, like the suspected Cushing's presentation, or maybe slight obesity, even presence of diabetes, because many a times Cushing's is hidden behind the secondary diabetes, and mild Cushing may not be obviously clinically visible. So we need to be excluding those in this situation. 9% of the total tumors were growth hormone secreting, so we need to be careful. And autopsy study showed around 40% were prolactin, 13% ACTH, only 2% were growth hormone. So this is normally the frequencies, and these three hormones need to be looked for to exclude the other association, whether it is actively functioning or not. And as interestingly, acromegaly patients where it is very difficult to detect early, 17% were incidental image findings of acromegaly presented as incidentalomas, 47% presented as a otolaryngological manifestation that is uncommon, like including hearing loss, sinusitis, tinnitus, where the patient was referred for that reason. And MRI did show a incidentaloma, which found to be a growth hormone secreting tumor. Another side of the story, that other side of the coin is hypopituitarism. That is another important area to be excluded first. So not only hyperfunctioning equally possible, like the baseline screening, including F24 TSH, cortisol, ACTH, FSH, IGF-1, testosterone in men and estradiol in women should be measured if needed. Dynamic testing, if the morning cortisol levels are hypocortisolism, then stress testing should be considered. Or stimulation testing. Similarly, stimulation testing of the growth hormone deficiency should be considered selected patient. If we suspect growth hormone deficiency, premenopausal women, normal menstruation usually does not require evaluation. Otherwise, these patients. Hypocortisolism is reported up to half of the patients of incidentoma of various etiologies, and deficiency of LH-FSH, testosterone growth hormone are the most common. ABP or the diabetes insipidus is fairly uncommon. So clinical symptoms also do not necessarily predict the hormone dysfunction because subtle deficiencies may not have the obvious presentation. So hypopituitarism need to be excluded because half of the incidentalomas of various etiologies, including adenomas, Rathke's cleft cyst, may present with hypopituitarism that need to be excluded as well. So these are the first testing, and LH, FSH, testosterone, TSH, and growth hormone need to be excluded unless obviously not required. So during follow-up, documented hormone hypersecretion of hypopituitarism and repeat pituitary hormone evaluation of all patients with macro and microadenoma of 1 to 2 years or earlier if the patients with new clinical symptoms. As I said, if the hormone evaluation is expected, at least the initial visit and 1 or 2 years visits, then it depends on the situation. New hypopituitarism, although not frequently, might develop. So at least two sets at the 1 to 2 years interval of hormonal assay should be done to exclude the possibility of future progression to hypopituitarism. And very rarely, clinically silent hormone expressing pituitary adenoma might transform into secreting adenoma. So again, these need to be excluded. For example, these are the study codes of 4 silent cortical adenoma and 4 null cell adenomas converted to Cushing's disease. So again, what it actually means is that we need to closely follow up, depend on the patient situation, though it is rare, but it is still possible. Silent somatotype adenomas develop into acromegaly, usually more aggressive than both non-functioning adenomas, and clinically overt acromegaly, usually refractory to treatment. So early detection and looking for it is more important. So ophthalmological examination as we require because of the optic nerve compression. So chiasma is important. So incidentoma more than 10 millimeter diameter and closing to the optic chiasma up to 3 to 5 millimeter need to be regular follow-up. Repeat visual field testing. If the patient has a supracell extension, then it is 6 months. With macroadenoma, then 1 to 2 years, and 6 to 12 months for the macroadenomas with annual MRIs of not compressing the optic chiasma. So it should be depending on how rapidly it progresses. And all patients with abnormal visual field test should be gone for a neuro-ophthalmologist and preferably look with the MRI for exclusion of the compressing tumor mass. So that is okay. Just a minute. So this is the approach in the nutshell. Maybe I will end my talk here because this is a very big topic. So pituitary function testing during follow-up and at presentation should be done. During follow-up, if the patient has a growth or if the patient has symptoms, then every 1 to 2 years. Otherwise, wait for it. Also consider cranial neuropathy and solid versus cystic tumor because solid tumor go aggressively high intensity in the T2 weighted and pituitary stroke deviation. All are the signs of rapidly progressing tumors, so that require more frequent evaluation. Then coming to the MRI, if the microadenoma, then repeat after 2 to 3 years. If the patient remains stable, uh, individualize if the image and if does not reaches close to the optic chiasma, and it depends on the new appearance of symptoms and others. If the patients of macroadenoma, whether it is less than 5 millimeter from the optic chiasma, then it should be more aggressively followed up, like 6 to 12 months. If it is not close to the optic chiasma, repeat after 1 year. And then growth are more than less than 5 millimeter from optic chiasma in subsequent follow-up. Then repeat every it is not there, then repeat every 2 to 3 years because it is not progressing, then we may lax the subsequent follows up and reassess needed continuous imaging. If the stable for 2 to 3 years, maybe we slightly prolong the situation. And third important component of follow-up is the visual field testing. At presentation again, if symptoms are present or if they're attributing to the closing to the optic chiasma that is less than 5 millimeter or closer to it, supracell extension is present, then repeat every 6 months, even if the patient is visual field initially was normal. And microadenoma less than 5 millimeter from optic chiasma, if it is not there, so it is safe, then we may not require a visual field testing in 1 to 2 years time. Or otherwise, if there is closing to the optic chiasma again, then we need to do it 6 to 12 months interval. I end my talk here. Thank you very much for your patient hearing.
Thank you so much, sir, for taking out your important time and sharing your knowledge on this topic, sir. I definitely think this session knowledge is going to help all the participants on their practice too, sir. So we have received some questions, sir. With all your permission, shall we take these questions one by one?
Yeah, go on it.
First question I can see, sir. Which serum marker is the most sensitive screening tool for ruling out growth hormone hypersection in the patient with pituitary incidentaloma, sir?
I didn't get you. Just a
Sir,
minute.
am I audible, sir?
Yeah.
Sir, the question is, sir, which serum marker is most sensitive screening tool for ruling out growth hormone hypersecretion in patient with pituitary incidentoma?
Depends on the patient's presentation. If the patient has telltale signs of growth hormone hypersecretion, it is ideally the growth hormone suppression test is better. But if we have low risk probability in the adults or even in the children, we IGF-1 levels are good enough for initial screening. But again, if suspected, confirmation is to be done by the growth hormone suppression test, which detects the not suppressible growth hormone level, which is important for the patient.
Yes, sir. Thank you so much, sir, for answering this question. Moving forward, we have another question, sir. If an MRI shows a pituitary lesion in the direct contact with the ophthalmic chiasm, what is the next mandatory clinical diagnostic step, sir? Can you please share some point on that?
I just repeat the point.
The question is, sir, sir, if an MRI shows a pituitary lesion in direct contact with ophthalmic chiasm, what is the next mandatory clinical diagnostic step, sir?
I have gone that follow-up slide itself. This is the thing what I am talking about. You look at the slide. It depends on the. They tell them to look at the slide. This slide is in the screen. So pituitary function is required if the patient has telltale symptoms, or even the initial screening if the pituitary MRI shows microadenoma, and microadenoma, depending on the size, we repeat the sequences. A follow-up of the repeat MRIs, and again the visual field is important if the tumor is closer to the optic chiasma, or it is enlarging in size, or the patient has other symptoms. And otherwise, if there is no supracellular extension or it is microadenoma, maybe we delay the subsequent visual field screening. So it all depends on the situation. That's why I made a flow chart. So this is not my flow chart. This is actually the guideline flow chart, how it to be followed up. And these are important factors written below. You can see cranial neuropathy, solid tumors, high intensity in the pituitary imaging, and the pituitary stalk deviation are more suspicious of aggressive tumors that need to be closer follow-up.
Thank you so much, sir, for answering this question, sir. I hope it will be very much helpful. One feedback from Dr. Subramaniam. He has written very important topic. Thanks for presenting. I hope, sir, that Dr. Subramaniam has really enjoyed this talk show, sir. Sir, I can't see any further question. I hope, sir, you have done justice to this topic and able to solve all the questions related to this. As there
Okay.
is no more questions, sir, with all your permission, shall we conclude this webinar for today?
Yeah, sure.
Yeah, sir. Take care, sir, and we would like to see you in future also. It was great honor to host you, sir. Thank you so much for your valuable time. And I would like to thanks all the audience who has joined this talk show and make this informative one. Thank you, sir.